Yeah, so we are live now. Hi, good evening to all. Welcome to this month's edition of NCSI's News Bulletin. As you know, our News Bulletin is a part of the ongoing e-educational activities of the Neurocritical Care Society of India. And every month we conduct this News Bulletin. And over the last few months, we have discussed recent articles on traumatic brain injury, on acute ischemic stroke. There was even an article about brain death estimation. And on the lines, we promise to bring you another interesting article and our take on it. This month's article is on intracerebral hemorrhage and BP monitoring in the intensive care phase. So the presenters today are from Apollo Hospital, Hyderabad. The article will be presented by Dr. Melvin. He's a DRNB resident from Apollo Hospital, Hyderabad. He's doing his second year DRNB in anesthesia. And this session will be moderated by Dr. Yagna Munesh. Yagna Munesh is an associate consultant in the Department of Neuroanesthesia, Apollo Hospital, Hyderabad. So welcome you too. And before handing it over to the presenters and moderator, we would like to start a new a part of this series. We just want to conduct something in the form of a journal watch where we want to tell the audience about what new articles have been published regarding neurocritical care in the well-established journals. So I will just go through a few articles. Let me not take too much time. Let's see if we can get it through fast. Okay, so I'm sharing my screen. I hope my screen is visible. Is it visible, Dr. Melvin?
Yes, sir. Yes, sir, visible.
Okay, so let's just go through quickly the new articles that have been published regarding neurocritical care. This first one is from the Lancet Journal. This is regarding acute ischemic stroke and the role of balloon guide catheters for endovascular thrombectomy in patients with acute ischemic stroke due to large vessel occlusion. This was a multi-center trial that was done this year in 2024. This was planned over a period of 7 to 8 months, but they had planned to recruit around 1,500 patients, but they did stop midway because of futility. Now, the rationale behind doing this trial was previously balloon guide catheters were shown to be beneficial during the period of retrieval of thrombus, because flow reversal is possible with balloon guide catheters that helps in better retrieval of the thrombus. But the futility was that there was no significant difference in the modified Rankin score at 90 days. They were more in favor of poor outcome, as we can see from the screen. And this poor outcome was attributed to flow occlusion, or a temporary flow arrest during the period of inflation of the balloon guide. So we request the audience to please go through the journal article. The second is the PROST2 trial. It is the role of intravenous recombinant human pro-urokinase for acute ischemic stroke within 4.5 hours of stroke onset. This was also another non-inferiority randomized control trial done in around 1,500 patients, as you can see here. Now, the rationale for this study given by the authors and the journal published in Lancet Neurology was that there is an increasing need for more and more agents or thrombolytic agents for stroke, and they have tried the role of pro-urokinase. Pharmacologically, it may be a fibrin non-specific drug that is proven to be effective in intra-arterial thrombolysis for stroke, and they have tried the role in intravenous. And as you can see, good outcomes was achieved in the form of MRS of 0 and 1 in almost 70% of patients who were given pro-urokinase when compared to alteplase, and they showed that pro-urokinase was non-inferior to alteplase for thrombolysis in acute ischemic stroke. The following articles are from the Neurocritical Care Journal, published in the October edition this year. There is a systematic review regarding the predictive validity of the 4 score when compared to the GCS. The authors claim that this was the first article ever published, or the first systematic review ever published, that compares the role of 4 score over GCS in mortality prediction as well as in outcome prediction, favorable outcome prediction. There are around 20 studies that they have incorporated in this systematic review. and they do show that 4-score is better when compared to GCS with regards to mortality prediction and as well as prediction of favorable neurological outcome. Although most of the studies were of poor to moderate quality, so it is important to go through this review and plan future trials accordingly. The next is regarding jugular venous catheterization and its role in complications in patients with aneurysmal subarachnoid hemorrhage. This was a retrospective trial. It was a single center trial where they showed that the use of internal jugular vein CVC catheters were not associated with increased complications in patients with SAH. The rationale was that it is possible that IJV catheters can raise the ICP during its placement as well as when it is in situ by preventing venous return from the brain. But they showed that they actually compared ICP values placed through EVD, and they did not find any increased ICP values with regards to IJV catheters. The next study is also from the Neurocritical Care Journal. This was a propensity score weighted analysis of short-term corticosteroid therapy for refractory pain following spontaneous subarachnoid hemorrhage. So what I did learn from this study was that there is a tiered approach to pain in patients with subarachnoid hemorrhage, and that's something that there is an institutional criteria that the authors have followed, and this is something that we can look up to. They did use steroid dexamethasone 8 milligram for 48 hours in patients with severe refractory pain, and they showed that it totally alleviates pain by not significantly. So this is part of the protocol for refractory pain, but may not be required as such. Very interestingly, in the same journal, in the same edition, Dix has written a review on the role of corticosteroids in acute neurology and neurosurgery. The claim is very simple. The idea of why not give it a try is not feasible with corticosteroids, as evidence in neurosurgery is favorable only for peritumoral edemas, where it can reduce the edema and the symptoms, whereas in other conditions it has not shown any favorable effect. The last one is, and this last but one is regarding long-term outcomes after severe acute brain injury in mechanical ventilation. Also a single center prospective observational study. Now this looks at the role of the surrogate decision markers, how the surrogate decision markers are affected in patients with acute brain injury in the long term. And they did show that the functional independence was achieved in only up to 35 to 40% of patients over long term in patients with acute brain injury, and that the surrogate decision makers during hospital stay did undergo significant level of psychological stress and post-traumatic stress disorders. So it's a different take. It's an interesting take that also is worth a read. The last is augmented renal clearance. We've had quite a few studies on augmented renal clearance. This is on prevalence, risk factors, and underlying mechanisms in patients with subarachnoid hemorrhage, also published in Neurocritical Care Journal in this October. They show that the incidence of ARC is around 80%. It is more in younger patients, those who had a higher blood pressure during ICU stay, and it lasted for almost 5 days. And they suggest that creatinine clearance should be monitored frequently in patients with subarachnoid hemorrhage in the ICU. So that's the recent articles that have been published in Neurocritical Care. So maybe over the next few editions, we'll be following this trend. We'll be apprising the viewers of new editions that have been, new journals that have been coming up. So now I'll hand it over to Dr. Melvin. He'll be presenting on. It's an interesting article. How intensively would you monitor blood pressure in patients with intracerebral hemorrhage? So let's hear it from Dr. Melvin. Over to you, Dr.
Is it visible, sir? Is slide visible, sir?
Can you go for slideshow?
Yes, sir.
Yeah, okay. Okay, your slides are visible.
Moving, sir. Is it moving, sir?
Yes. Go ahead, please go ahead.
Okay. Good evening, all. The study I am going to discuss today is continuous blood pressure indices during the first 72 hours and functional outcome in patients with spontaneous intracranial hemorrhage. So, this study was done by Mengele and colleagues, and it was published on 25th of October 2024 in Neurocritical Care Journal. My objectives will be review the acute management of spontaneous ICH, including the BP indices, and previous studies with discuss about the BP variability and evaluate the current observational study. So as we know, ICH accounts for 10 to 20% of all strokes, and early mortality rate is 30 to 40%. And predictors of worse outcomes are hematoma expansion, elevated blood pressure, anticoagulation therapy, and hyperglycemia fever. When we come to the management of spontaneous ICH also, we have given importance to the blood pressure lowering, anticoagulation reversal, ICP management, and surgical interventions. And the trials we know like ADAPT, INTRACT2, and ATTACH2, all those trials has also been mentioned about the systolic BP values that has to be targeted. And even the AHA guidelines in 2022, they're telling like if the patient is coming within 2 hours of onset, and if you are able to achieve the target of BP, within 1 hour, it is associated with good functional outcome. It has got a class 2 recommendation, and if the target, if you are maintaining around 130 to 150, it will more likelihood of development of a good functional outcome. So it has got class 2B recommendation. So other guidelines like ESO guidelines and NICE guidelines also telling about the absolute BP indices only. So what about BP variability, blood pressure variability? Of the previously mentioned trials, so many post hoc analysis and secondary studies has been done. In 2014, INTRACT2 and SUMRIDE trials data were collected from those trials, and they have found that there is some linear association with poor outcome in terms of systolic BP variability. And when we come to the in 2018 ATTACH2 trial, FASTMAC trial, they have done a secondary analysis. In that also they showed some linear association with poor outcome in terms of systolic BP variability. Even in 2023, MIMIC3 secondary analysis was also showing some amount of worse outcome with high systolic BP variability. So in a meta-analysis in 2021 by Leo and colleagues, they have tried to produce a forest plot which was showing that higher systolic BP variability was showing higher odds of development of poor outcome. So there are some trials which has shown negative correlation with the BP variability also, like they are telling that there is no effect, like CHIPS trials and COSAC's trial. So now we are coming to our study, that methodology. The study design is observational prospective cohort study. So the study is a kind of retrospective cohort because they have collected data from the local stock registry, and they have done the sample was 261 spontaneous ICH patient admitted in the ICU University of Hospital Tübingen. The duration was from 1st December to the 31st December 2020, and they have stratified patient based on class ICH classification system, and they have collected data, that is continuous data, from the BP arterial line they had. So from that, they have extracted the data using IntelliSpace critical care and anesthesia information software system during the first 72 hours of admission. And inclusion criteria for the study was spontaneous non-traumatic ICH patient who were admitted in ICU or intermediate care unit. And exclusion criteria were duration of hospital stay less than 24 hours, and any neurosurgical intervention immediately after the first baseline CT itself, or any traumatic ICH, or any tumor bleed, or any hemorrhagic transformation of ischemic stroke, or any patients who are withdrawn from the trial like from the medical treatment within 24 hours. And if there is any incomplete data on the functional outcome till 3 months of follow-up. When we come to the endpoints, the primary endpoint of the study was to assess the impact of BP variability on good outcome at follow-up of 90 days. So BP variability can be defined as variation in the BP during a period of time. So it cannot be represented. So for example, if sometimes BP is 90, sometimes it can be 190 also in a hyperacute ICH. So in such instance, we cannot use median mode to measure the mean value. So what we have to use is a dispersion tool. So they have used successive variation, standard deviation, and coefficient of variance. These three tools they have used to assess the dispersion of the data. So when we come to the standard deviation, it means that how the data are dispersed from the mean. So it will give the idea, but it will not tell the sequence of the values. It will not tell you which value is first, what will be the next value. That sequence will not be there. When we come to the coefficient of variance, it is actually derived from the standard deviation itself. So it is telling like that standard deviation data, they have adjusting to the trends of the map. That is the role of coefficient of variance. So it has also got the same problem with like that of standard deviation, because it will not give the sequence of the data. So that's why they have done a successive variation where we can see the nearby values. But the problem is that the interval, the space between those values are not mentioned. It may be different for one patient, it may be different for the other patient. So that is the drawback of successive variation. So that using these three tools, so the standard deviation and coefficient of variation, both are considered to be a best tools in absolute measure and relative measures of calculating dispersion of data. And secondary outcome endpoint, they have mentioned about the systolic absolute BP indices like systolic BP, diastolic BP, mean arterial pressure at the time of discharge and at the time of follow-up of 3 months, 90 days. And coming to statistical analysis, they have performed using SPSS software, and Shapiro-Wilk test was used to assess the data normality, and chi-square test was used for categorical variables, and Manu test was used for continuous variables. Continuous variables were represented in terms of medians with interquartile ranges, and categorical variables with the total number with percentage. And BP variability, they have calculated using the data software, that IntelliSpace data software are 4.2.0. Now we are coming to the proper results of the data. From this table, we can see that the mean age of the patient for the study was 69.6, but higher age group patients had poor outcome with a clinically significant value. And when we come to the pre-admission MRS score also, higher the value had more chances of developing the poor outcome. When we come to the baseline criteria, like median NIHS score, median ICH score, we can see higher values were associated with clinically significant association with poor outcome. When we come assess the risk factors most common for the poor outcome group was the arterial hypertension, followed by atrial fibrillation, and followed by the diabetes. And when we come to the anticoagulation on admission, the patients who were having more of anticoagulation on the admission time had more clinically significant chances of developing poor outcome. And even ICH volume also were associated with poor outcome. Even though there was a numerical difference in terms of early hematoma expansion, but there was no clinically significant p-value for both groups. When we come to the reversal of anticoagulation, they have found that from their data, people who got more reversal were associated with poor outcome. And when we come to the discharge criteria, the discharge modalities, then mortality was higher for the poor outcome group, obviously. So what they have done is a logistic regression analysis of the categorical data to get a binary outcome. They have seen that age CHADWA score was negatively associated with the likelihood of developing a good outcome. And even the baseline characteristic of high NIHS score and high ICH score and a high ICH volume was negatively correlating with a good outcome. And GCS, we can see that higher GCS has 22.3% chance of developing a good outcome. And they have noticed that any reversal of anticoagulation was showing a negative correlation for the good outcome. This was because the amount of the patient who were having poor outcome at the time of initially itself, their number was higher. 49 patients were included in the poor outcome group. So that's why their treatment also increased. So they developed. That doesn't mean that the treating anticoagulation is causing a poor outcome. So now we are coming to the primary outcome of the data. Primary outcome. So this data is actually we are seeing absolute BP indices only. So what they have done is they have divided that values they have collected into different time frames. So at the time of admission, first 2 hours, first 8 hours, 12 hours, 24 hours, 48 hours, 72 hours. So like that, they have made a time frame, and they have checked for each values, like each absolute index, systolic BP, diastolic BP, and mean arterial pressure means they have seen. So they have noticed that all the initially only from the admission time to the 72 hours, they have noticed that the systolic blood pressures mean were less in good outcome group. The trend was continuing till 72 hours. It was consistently low for the good outcome group. One more thing they have noticed that the presence of diastolic BP, even though initially the difference was not clinically significant, but that the value was higher as the more of the values were added for the mean. By the 72 hours, we can see that there is a clinically significant amount of increase in the diastolic BP for good outcome group. So they did a logistic regression analysis of this absolute BP indices. They have found that systolic BP from 24 hours, first 24 hours data itself, it is showing there is negative correlation for the good outcome. But for the diastolic BP, they have seen that there is a positive odds for development of a good outcome. So they have found that there is some amount of positive correlation between good outcome and the high diastolic BP values. But when we look at the proportion of systolic BP values crossing 140, we know that it was associated with negative correlation with the good outcome. This is the data which we are focused on. This is the data about the BP variability. So in this BP variability data also, they have divided into different time frames: first 2 hours, first 8 hours, first 12 hours, and first 72 hours. Like that, they have taken the values and took the average. So we can see for each of the BP variabilities, like systolic BP variability, they have mentioned in terms of successive variation, standard deviation, and coefficient of variance. We are continuing that same trend down also. Diastolic BP, map, everything they have represented. BP variability has been represented in terms of successive variation, standard deviation, and coefficient of variance. So initial first 2 hours, we can see that the significant value, like that P value, was not actually significant for any of them. This may be because this initial 2 hours were the time when we will try to intensively control the BP and reach the target. So these patients maybe has been treated intensively to get the target BP. So that variability was not that much significant. But that as the time goes, that when more values has been added, they have found that when first we look at the successive variation of systolic BP variability. So systolic BP variability in terms of successive variation, we can see that there is no variation till 72. That P value was not clinically significant till 72 hours in terms of successive variation. But when we come to the standard deviation and coefficient of variance, we can see that if the patient was having a higher variability of systolic BP, there was association of more chances, more likelihood of development of poor outcome. That value, we can see that till 72 hours, the trend is continuing. And next we are coming to the diastolic BP. So in terms of diastolic BP variation, if you look at the successive variation data, we can see that the p-values are not much varying. It is not significant till 72 hours. But in terms of standard deviation or coefficient of variance, we can see that higher values goes for the poor outcome group. And we can see that p-value significance also, it is significant till 48 hours. So when we come to the mean value, mean arterial pressure variability also, in that also we can see that there is, even though there is no much clinical significance, but there is higher variability was associated with poor outcome. But in this data, we have to see that what they have noticed is that this in terms of standard deviation coefficient of BP diastolic BP variability, p values, if you see, when we add more data till 12 hours, the p value is actually decreasing. That significance is improving. But after adding 72 hours data, they have found that the p value again started to increase. So there it is showing some amount of non-significance again. So what they have done is they did a logistic regression analysis for this all variabilities, BP variabilities. They have found that systolic BP variability in terms of standard deviation and coefficient of variance was consistently showing negative correlation with the good outcome. But when we see the diastolic BP variability, initial 24 hours, it was showing negative correlation to the good outcome. But when they clumped more data, more 48 hours and 72 hours data, they have found that there is some amount of positive correlation for good outcome for diastolic BP variability. So what the problem with this data is that before only we know that the baseline characteristics are good for good outcome group. Initially itself we know that patients with good outcome has lesser age, pre-admission MRS score was better, baseline characteristics data was better, arterial like this risk factors were also better, anticoagulation usage was less. So baseline character itself were like good for the good outcome group. So the chances of confounding factors are more. So we cannot tell the causation of the primary endpoints. So what they have done is that they did a multivariate regression analysis. What they have done in this forest plot is that they made a model one, that is the baseline model. In that model, they have included the baseline data. They have found that age, pre-admission MRS score, NIHS score on admission, and anticoagulation on admission has ICH. these variables were having a negative likelihood of development of a good outcome. So they have found this line represents the confidence interval, and this represents the odds ratio. So we can see that it is far away from the line of no effect. So it is showing like some amount of negative correlation with the good outcome. But diastolic BP, if you see on the admission, it is that line is crossing the line of no effect. That means it may not be showing some good beneficial effect. But systolic BP is very close to that line of no effect, but still it is negatively correlated to the good outcome. So to this baseline model, they have added systolic BP variability and diastolic BP variability in terms of standard deviation. They have added to the data. So they have seen that the baseline variables were still showing the same conclusion. But when we come to the standard deviation in terms of systolic BP variability, we can see that it is very close to line of no effect, that confidence interval, but still it is showing some negative likelihood of development of good outcome. But diastolic BP was actually showing some positive correlation for good outcome, but still it was very close to the line of no effect. So what they have done is they have included more data, 72 hours data they have included, and they have checked for the standard deviation. They have found that the standard deviation of systolic BP was actually having some negative correlation with the BP variability, showing some negative correlation with good outcome. But diastolic BP variability in terms of standard deviation was that value, the percentage is actually improving. So it is showing some positive correlation for the good outcome. And this trend was continuing in, even if you check with the successive variation also, variability in terms of successive variation also, the trend was continuing. So 72 hours, they have seen that all the data, even if you add any number of data also, that consistency was there about the relation between high diastolic BP variability and the high systolic BP variability. It was continuing. So almost from, we can see almost from 11.7% to 20.8% increase is seen as we are collecting more data, more values. We are seeing that diastolic BP is actually 11.7 to 20.8%. There is increase chances of patient developing good outcome. So they have, from their regression analysis, they have found that they are like, it is actually supporting the previous data also. So if the systolic BP is less than 140, it is associated with good outcome. And if higher diastolic BP is present in the early stages, it is associated with good outcome, but we cannot tell it is causing good outcome. It is showing some correlation, maybe because of the preserved cerebral perfusion, or cerebral autoregulation is preserved, maybe because of that. But when we come to the BP variability, higher BP, systolic BP variability was actually associated with poor outcome, as it was supporting the previous studies. But higher diastolic BP variability was showing some amount of beneficial adaptive response, or maybe it is reflecting the preserved cerebral autoregulation. So they, by their multivariate analysis, regression analysis also, they have concluded the same findings, and they have also confirmed that if we can early containment of ICH and IVH volume, we can actually give a patient a good prognosis. If anticoagulation therapy is going on, then definitely the patient is having poor outcome. That also they are supporting the previous studies. So what are the strength of this study is that the study, it's a cohort study, so it has itself level of evidence, and they have all the previous studies, the secondary analysis, BP variability previous studies, they have taken intermittent values of BP, but this in this study they have taken continuous BP monitoring using arterial line in the first 72 hours. And there is chances of confounding effect is minimal because they have used a multivariate regression model analysis to use. But when we come to the limitation, this study has got so many limitations. So that they have omitted the patients with a severe presentation of ICH, they have omitted. And BP variability itself, because it can have different phenotypes. For example, if elderly patients will have poor BP variability, like they cannot tolerate BP variability. Younger patients, so that phenotypes can differ. So some diabetic patient with autonomic dysfunctions will have more variability. So that may be that representing that that may be a consequence of their baseline characteristic, not because of the predictor of not at all a predictor of ICH outcome also. Then they have used so much of statistical tests, so there are chances of development of more false positive results. And they have used ABC by 2 rule for calculating the ICH volume. So it can underestimate or overestimate the ICH volume. So it is also a limitation. And they have followed up the patient for only 90 days, which is not actually good enough for a recovery of patient with ICH. And it is a monocentric study, so we cannot tell the causality is challenging, but we can tell it is correlating some amount of BP variability is correlating to the outcome, but we cannot tell it causing that definitive outcome. We cannot tell. And they have used another limitation is that they have in initial 72 hours that patient may be in ICU, the patient may be getting intubated, or the patient may be getting shifted for surgery in the OT. So they may be undergoing some procedures in between also. At that time also, the patient can have BP variability. So that thing we cannot neglect. And next thing is that the antihypertensive therapies also, they must have been patients, different patients may be getting different antihypertensive, so half-lives can affect. So all this can contribute to BP variability. So there are so many confounding factors which need to be discussed further. But to conclude, that prognostic significance of BP variability, particularly in diastolic BP variability in the acute phase of ICH, need to be studied with future prospective studies. And BP management should be tailored to individual BPV patterns, and we can use electronic health records or artificial intelligence in acute ICH care. And future research should be aiming to incorporate both cerebral autoregulation and BP variability, which will influence the ICH outcome. Thank you.
Thank you so much, Dr. Melvin, for the detailed appraisal of this article. So despite its limitations, it gives us a new dimension of thinking that till now the focus has been on the static BP targets, but then now we are moving on to the dynamic blood pressure targets also. And this article, yes, it identifies blood pressure variability as predictor of outcome, and then it adds to the existing literature. And this article also reaffirms certain already present literature which we know regarding the severity of NHS score and its the outcome of the patient with the spontaneous SAH as ICH. And the end conclusion that the high diastolic variability and low systolic fluctuations is associated with good outcome is a new contribution. So now adding to the strength of the studies, now this is an very exploratory and it is a data driven. And the statistical analysis they have used also is very multifaceted and it's a robust statistical analysis. And as you said, it accounts for the confounding factors. And as you were telling that it does not establish a causality. So this being an observational study, you can never have a direct establishment. You can just have a correlation between the outcome and the blood pressure variability. Now, the question is, the one big limitation is that what we have to address is the consistency between the blood pressure variability and the outcome. So the consistency between the blood pressure variability and outcome, just on the basis of an statistical analysis standpoint view, I don't think it is correct, and it is not fully understandable. So now this opens, as you said, that what future we can do. So this opens up to many things. So one is that whether interventions we put in to modify the blood pressure variation, how it will affect the outcome. So you have some intervention you're doing, for example, to limit the blood pressure variation by using intravenous labetalol infusion, or reducing the stressors so that the blood pressure peaks and are not there, having a good sedation protocol. So these all things will reduce the blood pressure variability, and these interventions, do they influence the outcome? And if we are able to establish through the randomized controlled trials and all, then I think the big limitation of this consistency between the blood pressure variation and the outcome can be addressed in a better way. And I was also seeing that in artificial use of artificial intelligence and all in your slides. So yes, so there was this articles I've went through where they have used closed loop systems. So they have used closed loop systems where the intravenous antihypertensive will be going on, and based on the patient blood pressure parameters, it will be titrated. So we can have an more controlled approach, but then it also has its limitations. But then these are all the things which we can try. So, and to make sure that it's the blood pressure just based on this static blood pressure targets is not enough. So what we have been doing, so that the concept of one size fits all is, I think this study gives us a new dimension, that we have to look at the dynamic targets, and then we have to look for the interventions to reduce the blood pressure variability, and now again do a research on look for any other randomized control trials and how it is affecting the outcomes. So this is from my side. So anything else you would like to add?
So, first of all, thank you, Dr. Melvin, and thank you, Dr. Munesh, for this presentation. For those who have read the article, if I use the adjective crisp, it won't be sufficient, because the article gives you tables and tables of data, and Dr. Melvin and, of course, you, Dr. Munesh, have summarized it beautifully. Yeah, so look, see, everybody wants to analyze a trial and try to point the flaws in the trial. What When I went through it, I found that they could have given more detail regarding those patients who underwent endotracheal intubation, because we as anesthesiologists and intensivists, we know we use different drugs and they cause different effects on the hemodynamic parameters. And as Dr. Melvin mentioned, the use of antihypertensives may not have been uniform. Different patients may have been given different antihypertensives as well. The plus for us is that it opens up another new hemodynamic variable. The existing literature and the guidelines and recommendations were all based on systolic blood pressure and mean arterial pressure. We may have just thought that this diastolic blood pressure is an inherent component of mean arterial blood pressure, and we may not have to look at it individually. But here, it's not just the DBP; it's the DBP variability that they want us to look at it. So the gross information that we get out of it is make sure there is no gross variability of diastolic blood pressure, isn't it? So that may have help in better outcomes in patients with intracerebral hemorrhage. So yeah, so if I would want to do another trial regarding the parameters, or taking something out of this trial, I might want to focus on the role of anesthetic agents or streamlining antihypertensives, and again looking at the same parameters or adding something new. So that's something that I hope that something of that sort should be the take-home message from this discussion. So thank you very much, Dr. Melvin. Thank you very much, Dr. Munesh. And we do have one question. Dr. Kalicharan Das has posted, what is the cost difference between pro-urokinase and altiplase? First of all, pro-urokinase is not available in India, so we don't know what is the cost in rupees. In Western countries, the trials mentioned pro-urokinase is said to be half the cost of altiplase, and which is probably one of the reasons why it is being developed as an intravenous agent. It has been in use as an intra-arterial thrombolytic agent, but 4 times dose is required between intra-arterial and intravenous agents. As far as I know, it's around 9 milligram is recommended for intra-arterial and 35 to 50 milligram for intravenous thrombolysis. So still, it would be one half of the cost of altiplase. Maybe that's the reason why they are developing it as a newer agent. But as far as I know, it's still not available in India. So yeah, so that's the only question that we had. Any final comments, Dr. Melvin, Dr. Munesh?
That's all, I think, sir.
Okay, so thank you so much, Dr. Melvin, Dr. Munesh. Please do go back and read this article and try to correlate with what we have discussed here. You will understand why I mentioned Dr. Melvin has crisply summarized the article. And once again, this is the end of the academic session. So academic year actually, and best wishes to all the exam going candidates who are appearing for neuroanesthesiology, neurocritical care, and critical care examinations in India and all over. Thank you to the audience. Please do stay tuned for another episode which is coming to you very soon. Thank you, Dr. Melvin. Thank you, Dr. Manish.
Thank you, sir.
Thank you, sir. Thanks for the opportunity.
Thank you.